Hello everyone, today I'm going to talk about Gamma, Rama, Garma. Multimodal analgesia is the mantra. My name is Dr. Shiv Kumar Singh. I work as a consultant in anesthesia at the Royal Liverpool University Hospitals. Now you must be wondering why I'm showing you this image of children crossing the road. This is a story in some of the areas in India where children cross the rivers every day to go to school. But we could actually provide them boats. But the boats have to be manned by people, and there is going to be, times when they will not be available to them. Or we could actually build bridges across the rivers, and this will allow children to cross the road without depending on anyone. They could actually come and go as they wish. So you must be wondering, what's the point in this? The point is be greater than average. And to be greater than average, you need to work differently. You need to work intelligently. So Rama, Gamma, and Garam. What are these? So Rama is basically regional anesthesia combined with multimodal analgesia. GA plus MMA is Gamma. And when you combine GA and regional anesthesia, that is Gara, with multimodal analgesia, which is one of my favorite technique, it will become Garma. Garma is also uh, in our language, Hindi, it is garam, garam, or garam is hot. Okay, so there's something which is very hot, like a hot topic. So GA plus multimodal analgesia makes sense because we all know GA is opiate-based anesthesia. Analgesia has always been opiate-based traditionally, and there are other components like amnesia, hypnosis, and muscle relaxant as part of general anesthesia. But then opiates are not the solution to all problems. Opiates have their own problems. They're associated with lots of complications like respiratory depression, pharyngeal muscle weakness, negative inotropism, PONV, ILS, urinary retention, and whatnot. So there is obviously problem across the world with opiates. There's problems with procuring in developing countries. There's problem with legalization in developing countries. And there is a problem of addiction in US and UK and other places where opiates are freely used as part of analgesia. So we have tried to move towards opiate-free anesthesia from opiate-based anesthesia, so which we also call alpha. And there have been many reasons why alpha has become more fashionable. One thing was obviously related to the early recovery after surgery. Then others were related to sort of getting rid of the complication associated with opioids. Regional-based anesthesia relies mainly on regional anesthesia, which provide analgesia, and it provides anesthesia to that region where the surgery is going to be. So when we talk about Rama and Garama, he says, why is multimodal analgesia necessary with regional anesthesia when it is providing the anesthesia to the local part and it is providing good analgesia? You look at these eyes. Can you see the pain? Now, pain comes from higher centers as well. This is the emotional aspect of pain, which we are not taking care of with regional anesthesia. In a publication in 2000, Cousins, Power, and Smith actually wrote this statement. It said that it remains a common misconception amongst clinicians that acute postoperative pain is transient condition. No, it is not transient. It goes on for days and weeks, and it obviously has got this tendency to become a persistent post-surgical pain or chronic pain if we don't deal with it appropriately. The chemical mediators which are released in acute pain, that is, in response to any injury, are no different from what we talk about in the mediators in chronic pain. So, prostaglandins, 5-hydroxytryptamine, that is serotonin, bradykinin, histamine, calcitonin gene related peptides, substance P, these are all there in acute pain as well as in chronic pain. And tissue trauma is associated with physical, that we all know, but also cognitive and emotional discomfort. So when you're doing regional anesthesia, you're taking care of the physical part. You're not taking part of the cognitive and emotional discomfort, which is associated with the tissue injury. When you're doing regional anesthesia, you are actually blocking this at the spinal level. Okay. You're not realizing that the pain actually ascends, and it actually ascends via the ascending pathway and goes to the cerebral cortex through the diffuse projection to postcentral gyrus to hypothalamus to amygdala, where all the emotional aspect of the pain is integrated. Okay. So we need to take care of not only the local part but also the central part of pain. If we don't relieve pain post-operatively, which can happen with regional anesthesia, once the local anesthetic you have given the spinal anesthesia wears off, or once your local anesthetic wears off from your blocks. Okay. If you do not take care of the postoperative pain, which can be very severe when your local anesthesia actually wears off, can lead to clinical and psychological changes which are associated with increased morbidity and mortality, increased cost, and reduction in the quality of life. So, how big is the problem of acute postoperative pain? Warfield and Kahn in 1995 did a study and found that 3 out of 4 patients actually woke up with pain. Now that is very significant. And 80% of these patients actually had moderate to severe pain. Again, very significant. So that was in 1995. Down the years in 2003, Afflebaum also did a study to look at acute postoperative pain, and he also found that moderate to severe pain was present in 80% of the patients, that is in the postoperative period. Then coming back to 2014, TJ Kahn also actually studied acute postoperative pain, and this is what he found. He said that 86% of the patient experienced pain in the postoperative period. Of this 86%, 75% of them had moderate to extreme pain in the immediate post-surgical period. And 74% of the patients were being discharged to the ward with pain. So these patients still actually were suffering from pain after they were discharged from the ward. So, like I have already mentioned, acute pain does impact patients' lives. It increases the hospital stay because if you do not manage pain properly intraoperatively, then you have to manage in the post-operative period. You have to use opioids or other analgesic which may be associated with complications like post-op nausea and vomiting. So their stay in the recovery increases because they're still vomiting or have other side effects. They cannot be discharged home, or even if they're discharged home, they might actually come back to the accident emergency department for readmission. Also, there is a reduction in the quality of life because of the pain. They cannot function normally. There is impaired physical functioning. There is reduction in functional recovery. Obviously, there is increased complication, and pain doesn't allow them to sleep. And this has been seen in multiple studies throughout. It has also been seen that inadequate acute pain management can move on to chronic pain in almost 50% of the patients. Now, that's not good. Again, proven by multiple studies. Why does this happen? That's because of the peripheral sensitization. The tissue damage, the inflammation, the activation of sympathetic afferents or efferents actually create the sensitizing soup. All those kind of mediators are released, which actually convert the high threshold nociceptors to low threshold nociceptors. So now these nociceptors now respond to innocuous pain. And if this winding up actually continues, peripheral sensitization continues, this will progress to either persistent post-surgical pain or to chronic pain. So what is the role of multimodal therapy in this? How can we use multimodal therapy so that patients do not suffer? So in 2012, ASA Task Force on Acute Pain Management produces practice guidelines for management of acute pain in the postoperative setting. They define multimodal therapy as synchronous administration of two or more pharmacological agents, so these agents or approaches, each with a distinct mechanism of action. So it's not that giving morphine and then fentanyl that comes to the same group. You need to be actually using two different agents, okay, from different categories. So non-steroids for opiates or paracetamol for non-steroidals or giving nerve blocks of that. So it's about more than two pharmacological agents or approaches. They also said that we need to be targeting different pain pathways. Okay, so not only looking at peripheral but also spinal or central methods, and use synergism of these multiple agents, which will allow for dose reduction of individual agents and thus reduce the risk of adverse effects from individual agents. They had few key practice guideline recommendations which are very important. First of them actually said that anesthesiologist or anesthetist should be using regional anesthesia techniques like epidural or intrathecal opioids. Or if the patients can't actually get epidural or intrathecal opioids, then use systemic opioids as patient control analgesia. And use regional anesthesia techniques like peripheral nerve blocks or even local infiltration to improve postoperative pain management. It also said that the analgesics, simple analgesics like non-steroidals or COX inhibitors and paracetamol should be given round the clock. Okay. And the dosing regimen should be understood to optimize efficacy while minimizing the risk of adverse events. And that's only possible if you combine multiple agents. Okay. And the choice of medication, the dose, route, and duration of therapy need to be individualized. So not all patients can. For example, some patients may not be able to directly take non-steroidals. In that case, can we use a different group of non-steroidals or use something else instead of non-steroidals in these patients? So pain prevention team or preventing pain actually involves everybody. It involves the surgeons, it involves the nurses, it involves anesthetists, physiotherapists, psychotherapists, but also involves the patient as well. Okay. So patient has to be part of this management. Nociceptive stimulation or nerve injury leading to pain involves neuroplasticity that is affected by the genetic buildup of the patient, the age of the patient, the memory that is based on the experience, previous experiences, their mental state, their activity states. Okay, these all factors affect pain globally. And this is then modified by the anesthesia we use, adjuvants we use, and also the surgical techniques used for particular operations. So multiple modal therapy actually starts from the periphery, goes to the spinal cord, through the brainstem and to the central nervous system that involve the limbic cortex, that is the emotional aspect, the sensory cortex where we sense the pain, the, and the thalamus. Okay. So we should be able to actually use all various agents at different levels. So whether you're using local infiltration at the site of the operation, anti-inflammatory agents act where there is inflammation, okay, giving nerve blocks locally, using opiates and other local anesthesia at spinal level, and also giving agents that actually act at the central level. Okay, so we need to utilize agents which act at all different levels. So multimodal therapy in practice, how we can practically use, and that's what I'm going to discuss now. And if you look at my armamentarium for multimodal analgesia, there are no opiates involved in this. In our setup, even tramadol actually is kept in the CD cupboard. It's locked up, okay, so you'll have to actually sign for it. So these agents are freely available in your cart. So you have local anesthesia for giving blocks or spinal for epidural or infiltration. You have non-steroidals like your diclofenac IV. You have lidocaine, which you can use IV, magnesium sulfate. Okay, catapres or the clonidine is available to us. Dexmedetomidine is very costly. It's not available freely to us. Dexamethasone freely available to us. But if you actually have to use ketamine or tramadol, you will actually have to sign for it and get it out from the CD cupboard. But these are easily available to us. So we will look at examples. Like for example, we will take a simple surgery like a hernia repair. Now, where we're going to do a mesh repair. So to provide appropriate analgesia and anesthesia, we need to understand this surgical anatomy. So we need to actually look at what kind of the hernia it is. Is it a direct hernia, indirect hernia, or femoral hernia? You'll also see there are actually nerves involved, so you can actually see that the iliac nerve moves along with the cord. Okay. Then there is a hypogastric nerve that may be involved in the incision or in the scar tissue. Okay. So if you look at components of hernia repair, it involves ligation of the hernial sac. It may involve that the surgeon might actually have to cut through the nerve. One of our surgeon does it regularly. He cuts through the iliac nerve. The nerves can get entrapped in the mesh or in the scar tissue. Again, it depends whether the surgeon is, where is the surgeon actually fixing your mesh? Is it taking a bite through the periosteum, which can lead to periostitis? What's the approach? Is this an open approach? Okay, is it open repair, or this is a laparoscopic repair? That also actually, affects the, outcomes. Then there is experience of the surgeon, how good he is at dissecting the area. Also, experience of the anesthetist. Can the anesthetist give nerve blocks? Okay. Okay, are they experienced enough to use regional anesthesia techniques? The complications associated with the surgery, whether we're introducing foreign material, if we're using a mesh or using tacks. Again, I explained about periostitis. And obviously, there is going to be, the hernia can be going along the sac and it can cause orchitis. So all this can cause pain relief or pain or need pain relief as well. So this is my inguinal hernia repair analgesia plan, depending on the basic setup, intermediate setup, or advanced setup. Advanced setup, you got everything. You got nerve stimulators, you got ultrasound guided, you got opiates, you got everything. So we're now going to talk about this. Intermediate setup, they might actually have some of these things, but here we're going to talk about basic setup or rural setup or setup where there are limited resources. Can we actually provide good multimodal analgesia and anesthesia in a limited resource centers? So normally we all start off with a checklist. We then apply the monitoring. We secure an IV access. Then comes the induction, which propofol is commonest induction. And then you insert a supraglottic device. And you leave the patient to breathe spontaneously. You monitor the vitals. Once the patient is stable enough, okay, it's established on the thing, you fix your supraglottic device. Then you are going to give them IV dexamethasone, because in awake patient this causes quite a lot of discomfort. So you do not want to actually give dexamethasone when patient is awake. Same thing Voltrol. Voltrol IV is very painful giving through IV access. You need to dilute it. So minimum dilution of 20 mLs. Or you can actually put it in a 100 ml bag and run it slowly. So you need to actually give this. So soon after this is done. So while I'm preparing for my block, okay, this has all been delivered. So next step is actually to do the blocks. Now people do classical approach. Classical approach involves 2 centimeters from the antisphilic spine going medially and upwards or downwards. Now, if you use this landmark at this level, the ilioinguinal nerve actually has, pierced the internal oblique and lies now between the external oblique and internal oblique. So you need to deposit a local anesthetic in 2 planes. So you need to deposit in the tap plane, as well as, that is a plane between the internal oblique and transverse abdominis, as well as from internal oblique and the external oblique. So it's better you do that. But also at the same time, if you are actually blocking here, you are going to miss out the lateral cutaneous branch, and hence you will likely have to ask the surgeon to do a local infiltration of his incision site. Okay. So classical hernia block may not provide you most appropriate anesthesia. So what we have described is this landmark where both these nerves are lying together in a single plane. This is the approach. This is ilioinguinal and iliohypoglossal nerve block in the transverse abdominis plane. For this, you need to actually mark the anterospheric spine, go 2 inches or 5 centimeters cranially, and then from that point go 2 inches or 5 centimeters posteriorly. And that point, this point actually lies almost in the mid-axillary line over the iliac crest. So when you go there, you do exactly like you will perform a tap block. You will feel 2 pops and deposit local anesthetic here. At this level, in most patients, 99% of patients, both the nerves, ilioinguinal, iliohypogastric, are lying here, and you will also catch the lateral cutaneous branches as well. Okay, so we're going to do right inguinal hernia block there, so you can see that I'm marking that anticephalic spine 2 inches above, 2 inches on the posteriorly. So you go 5 centimeter cranially, 5 centimeter posteriorly, and then you look for 2 pops. So you go through that and you actually feel for the 2 pops through that. And I have used a nerve stimulation here, and I can actually see that there is twitching of the abdominal muscles as well. So you can use nerve stimulation to stimulate the ilioinguinal iliohypogastric nerves as well. And as soon as you inject the local anesthetic, the twitches will disappear. Okay. So this is the ilioinguinal and iliohypogastric nerve block in the transverse abdominis plane. Okay. When you're doing hernia surgery, you also need to block the spermatic cord, and spermatic cord block can also be done by anesthetists, but better left to the surgeons. The surgeons can always infiltrate local anesthetic while they have dissected tissues. So you can always ask the surgeons to do this block. So once the blocks are done and the patient is now ready for the surgeon, during this time you can then also give infusion of magnesium sulfate. The dose for magnesium sulfate is 50 milligrams per kg body weight. Why magnesium sulfate? You can actually read about this or listen to this in my lecture on acute pain management. It's an MDA receptor blocker, and it's very, very important that it works locally at the spinal as well as central level. Okay. So 50 milligrams, say if you have 70 kg man, so that's come to 3.5 grams. And each 2 ml is 1 gram. So you're looking at around 3 to 4 ampules. Not 1, but 3 to 4 ampules. Okay, so 3 ampules is 12 millimoles, 4 ampules is 16 millimoles. So you're looking at 12 to 16 millimoles that need to be delivered slowly. Okay, you don't want to give them as a bolus. So tend to actually mix these in a liter of plasmolite or ringolactate. That's the fluid I'm going to give through. So this is going to go slowly over the hours, every hour. So it's not given as suddenly. So you didn't see. Once the surgery is over, towards the end of the surgery, around 20 minutes before the skin closure, I start the patient on paracetamol, IV paracetamol, and the patient actually wakes up as a combination of these they to wake up. Now, if you think your block hasn't worked very well or you think you have missed a segment, you can also use a mix which I have described, wherein you give 1 gram of paracetamol along with 25 to 50 milligrams of tramadol. So, in a small build patient or a female patient, you don't need more than 25 milligrams of tramadol. Now, the other advantage of giving tramadol, it not only provide analgesia, but giving this small dose slowly does not cause nausea and vomiting as is associated with bigger doses. So you're not giving us a bolus because you'll be giving this over 20 minutes along with the infusion. You do not see any nausea and vomiting associated with tramadol. At the same time, tramadol also reduces the shivering that is associated with cold. The patient tend to drop their temperature in the operation theater. It reduces shivering as well. Lignocaine can be used in cases where you can't give blocks. Okay. In these cases, like you can actually use lignocaine at 1 milligram per kg bolus. This can be followed by 40 microgram per kg per minute infusion during the surgery. This is then reduced to zero point 0.5 to 1 milligram per minute. So almost you're looking only around 30 to 60 milligrams per hour. Thank you. And then you continue this into the recovery and the post of day one. And if you look at the post of day one, you also need to make sure that the patient directly started on, once they start taking orally, then you start them on other oral analgesics as well, like oral paracetamol, oral ibuprofen. Okay. You also need to monitor patients for signs of toxicity like tinnitus, perioral numbness, cardiac dysrhythmias. Okay. And second post-op day, you actually discontinue on the second. So it goes on till first post-op day. You can use this. So I said that the tramadol we only use around 20 to 50 milligrams. The rest of the 75 to 50 milligram which is left, it's better to actually dilute it into 10 mLs and keep it for post-operative pain. So once the patient has woken up, and if there is still pain, you can actually use this as small bolus. 10 to 20 milligram IV boluses actually work very well for residual pain relief, okay, or residual analgesics. So like I said, if you're unable to actually do blocks, you can use IV lignocaine. You can also ask the surgeon to do a local infiltration, and the local infiltration need to be done at the beginning of the surgery, not at the end. Then there is no point. If you do in the end, the analgesia lasts for a very short duration. But what I was experiencing that the analgesia lasts for maybe for 4 to 6 hours. But if you do it before the incision, then the analgesia can last for 14 to 18 hours. And giving IV dexamethasone improves the duration of analgesia not only with the nerve blocks but also with local infiltration. So you don't actually have to give it mixed with the local anesthetic. Giving it IV not only prolongs your analgesia, it also prevents your nausea and vomiting. So you're already giving one antiemetic for the patient, so you're reducing the risk. Anyway, you should be assessing the patient in terms of AFL scores for their risk for post-op nausea and vomiting and treat it accordingly. And also, if you are not able to give the blocks or for whatever reasons, soon after induction, you can also now give the paracetamol and tramadol mix at the very beginning itself. Okay, so you don't actually wait towards the end, you can actually give at the beginning of the surgery as well. In the recovery, do not forget to prescribe pain relief and post-op nausea and vomiting. So you have already used dexamethasone, you can then prescribe them for ondansetron and Stemetil if you like. Post-op instruction for the ward and home need to be very, very clear. One thing, if the patient is able to take by mouth, the patient should be actually encouraged to take their oral painkillers by mouth. Second thing is that the analgesia in the first 48 to 36 to 48 hours should be given by the clock. It need to be regular. You do not give them analgesia per demand because the oral analgesic you're going to use are going to take time to reach their pain relief levels in the blood, and there will be delay in the analgesia delivered to the patient. You can actually prescribe patients with simple analgesic like paracetamol. The dose is 1 gram. Okay, not 500 milligram. It is in the adults. The dose is 1 gram every 6 hours and maximum 4 grams in 24 hours. Okay. The ibuprofen should be given at the dose of 400 milligrams every 8 hourly. Okay. There are fixed dose multimodal combination available easily in the market, like Tremacet, as you know, paracetamol and tramadol combination, fantastic combination, can be used along with non-steroidals like ibuprofen to provide excellent analgesia in the post-operative period. Astamin, the paracetamol and tramadol combination can be given 4 times a day, ibuprofen 3 times a day, along with food. It's better to actually take the non-steroidals with food to reduce the acidity. If the patient is not able to take orally, you will not discharge the patient home, obviously. So in the ward, you can continue giving them 1 gram of paracetamol every 6 hourly, along with 25 to 50 milligrams of tramadol. You can also use IV diclofenac. So the dose is 75 milligrams 12 hourly. You should never exceed more than 150 milligrams in 24 hours, non-steroidals. And if you're giving non-steroidal, don't forget to prescribe PPIs, so omeprazole, pantoprazole, esomeprazole, lansoprazole. Whatever is available to you, you can actually prescribe them to reduce the uh, acidity. So we described now as an example, describe how you would actually conduct multimodal analgesia in terms of the hernia, a common simple procedure. What about other abdominal procedures, like, for example, laparoscopic surgeries? You have to remember that the even simple surgery like ventral hernia repair or paraumbilical hernia repair, it can be done open surgery. So you need to know from the surgeon what approach are they going to use. You can look at the incision is different. The port sites are different for laparoscopic incision, and if it has been done robotically, the port sites again are different from the laparoscopic incisions. So you need to actually know the surgical anatomy very well. You also need to find out if the surgeons are going to use mesh along with tacks. Now tacks go into the abdominal wall and these can cause severe post-operative pain. So you need to be, even if it is a laparoscopic surgery, small ports, you say, okay, you can give local infiltration, but don't forget tacks can be, very painful. So main blocks that anyone can master using Lazarus. You don't need a nurse stimulator, you don't need an ultrasound, but you can actually master them. Okay, all you need is a blunt needle. Okay, so this is one of the technique used to blunt the needle. So on the right side, the green one is a 21G hypodermic needle. On the left side is short bevel blunt needle. Okay, you can then actually bend it into like a parrot beak. This is on myself, my skin, and this is on my hand. Can you see that it does not pierce? Okay, this is actually, I'm applying quite a bit of pressure on my hand and it does not actually go through it. This is called a cushion effect, which happens, and I will describe what exactly cushion effect is. So basically, you can use the needles, which actually have a short bevel. These are, difficult to pierce, so they give you good loss of resistance. You can use hypodermic needle, but for that you need to modify it. You need to actually convert them into a parrot beak. You need to blunt the tip or convert them to parrot tip. You can use epidural needle, 2 point needle. You can use pencil point needles. The spinal needles can be used, and I'm going to show that with blocks how these can be actually used. So blunt tip short bevel needles, they do not pierce the skin very easily because we have thick skin. All of us. The skin is actually has got a lot of resistance. You require a great force to actually pierce through the skin. Okay, who like rhino skins? And this is what it does. So when you apply a greater pressure with a blunt needle, the skin squashes the fat, and there is the tissues come closer together. Okay, that's causing. And when you try to feel a pop, so when you go through the skin, you might be actually going through the first layer of the fascia. Okay, so it's like your head actually getting buried in the cushion. So that's why I actually call this a cushion effect. This is described in my article on loss of resistance from 2011. Okay, so this is we're showing the, you can actually see that. Okay, I'll play it again. There you go. Okay, that is the cushion effect. You need to apply. You can actually see how the skin, when you pierce it, actually takes time to actually go through it. Yeah. Okay. So to you know, how do you get without actually causing cushion effect? So if you're using a parrot-beak needle, then you need to introduce a needle at an acute angle. So you use the sharp tip to pierce the skin, and once the skin is pierced, then you can actually then change it over to 90 degrees, and then when you go in, you actually feel the bounce and the resistance of the fascia very well. Okay. Or you can use a needle through needle technique, in which you use an introducer, sharp introducer through the skin and the fat, and then introduce the blunt or pencil point needle through that. So some spinal needles actually come with an introducer. These are actually then useful for these kind of blocks. Okay. So coming to some other abdominal blocks and surgeries and blocks. First thing, very important for abdominal surgeries is to understand the anatomy of the abdomen. So here we're talking about the transverse abdominis plane, and the plane through which the nerves actually move. So this plane lies below the internal oblique fascia. Okay, so just not under the muscle, internal oblique muscle, but under the internal oblique fascia, and it lies between the fascia and the transverse abdominis plane. Okay. And rectus sheath is covered by anterior and posterior rectus sheath, and when we do the blocks, we tend to actually have the local anesthetic deposited over the posterior rectus sheath, not under it. The other anatomy we need to know is about the chordatus lumborum, okay, and the transverse abdominis aponeurosis or T aponeurosis. So this is where the nerves actually pierce the transverse abdominis aponeurosis and then move into the trap plane. I'll show you that in a minute. Okay. So that is the posterior wall. So the posterior wall not only consists of the fascia from the internal oblique, which has split into two, but also the fascia transversalis. So there are two fascias which lies in the posterior part of the abdominal muscle. So when we are depositing the local anesthetic, we need to deposit it under the muscle, but over the fascia. This causes kind of a tremblance, which is normally actually seen in the ultrasound so well. You also have to actually remember that the rectus sheath is not constant. Okay, it actually is different at different places. So if you look at the xiphoid level, there is no posterior rectus sheath. There is only anterior abdominal sheath. And if you go below the xiphoid, so between the xiphoid and the umbilicus, you actually see anterior and posterior sheath. So the anterior sheath is tougher because it has got the external oblique fascia, as well as the fascia of the internal oblique, which has split into anterior and posterior sheath. So anterior sheath is always very tough. Okay, as you go below the arcuate line, the anterior rectus sheath is very tough, okay, because it has got three layers of it, and there is no posterior rectus sheath below the arcuate line. Okay. Also, you have to be careful with the inferior epigastric artery, which actually lies in this plane. So looking at the nerve as it originates, it passes anterior to the chordatus lumborum, and at the transverse abdominis aponeurosis point, it actually pierces the fascia, and then actually moves into the internal oblique, below the internal oblique fascia in the transverse abdominis plane. Okay, so the nerve lies below the internal oblique fascia and above the transverse abdominis plane. So if you deposit local anesthetic above the internal oblique fascia, you're not going to get a good block at all. Okay. This is showing how the nerve actually moves in the your internal oblique fascia It gives a branch, the anticutaneous branches. It also actually gives the lateral cutaneous branches. And so it's very important at what point you are actually going to deposit your local anesthetic. So when the local anesthetic is deposited posteriorly in the transverse abdominis plane, and then you actually get a good block. You will actually catch the lateral cutaneous as well. So abdominal transverse abdominis plane or tab block is normally given on the mid-axillary line. People tend to actually give it sort of midway between the costal iliac crest, and this actually only blocks the ilioinguinal and iliohypogastric nerves in 33% of the time. Also, when you're actually blocking this, you may not actually catch the lateral cutaneous branches as well. So these are not covered, and neither are the T10 and other branches. So it's not a very good approach. It might catch some of the higher branches, but those can be covered by a rectus sheath block. So the other approach is the classical approach where you go at the mid-axillary line just above the iliac crest, and this tends to actually block your lateral cutaneous subcostal ilioepigastric ilioinguinal T10. So this is at the Pethys triangle, the classical Pethys triangle level. So this is actually a good block. The other block, which is very similar to Pethys triangle but slightly anterior to it, is the ilioinguinal iliohypogastric nerves in the transverse abdominis plane. So for this anticipilic spine, we could move 5 centimeter cranially and then 5 centimeter posteriorly at this point. And this is the ilioinguinal and iliohypogastric nerve block at the in the transverse abdominis plane. So this will actually block the ilioinguinal iliohypogastric branches. You can actually also do a posterior tab block. Some people actually also call it quadratus lumbar block, wherein you actually pierce the transverse abdominis aponeurosis. Okay, and deposit local anesthetic there, and that will actually catch the nerves before they move into the transverse abdominis plane. The spread is considered to be a lot more extensive here, and you get the ilioinguinal iliohypogastric subcostal T10. You catch most of the nerves, so it's a good block check. There are other thing we need to know is the all the various surface marking, costal margin, lateral margin of the rectus abdominis. You can actually see it is actually wider at the top than at the umbilicus level, and then there's always linea alba and the umbilicus. So the fourth is a four-quadrant tap. So people actually often get asked, what is a four-quadrant tap? So when you actually give tap block in under the subcostal margin above the iliac crest, obviously you're going to do it bilaterally, and so that becomes four-quadrant. So tab block just below the costal margin, tab block above the iliac crest on both sides. That is a four-quadrant tab. Then there is a 4-point rectus sheath block. Okay, so this is not four-quadrant. In this case, we are actually going to divide the abdomen into 4 quadrants above the umbilicus. So between the xiphisternum and the umbilicus, you're going to divide. So the lateral margin of rectus abdominis, linea alba, umbilicus, the xiphoid. This is also 4 quadrants, 1, 2, 3, 4, and you actually then deposit local anesthetic over the posterior rectus sheath in these 4 quadrants. Okay. The reason being that anteriorly there are tendinous intersections. They do not actually go to the posterior sheath, so they won't actually cause any problems. So the local anesthetic would normally spread. But what we have seen with our experience with ultrasound, that local anesthetic, like in children, where you can actually just go on one point, and when you actually inject local anesthetic, spreads all over the posterior rectus sheath. It does not happen in adults. So it's better to actually inject local anesthetic at 4 points in adult patients. There are always some kind of additions always present in there. So deposit local anesthetic at 4 points. So like I said, you in rectus sheath block, you need to actually go through the anterior rectus sheath, which gives you a nice loss of resistance, go through the muscle, and then feel a bounce over the posterior wall or the posterior rectus sheath. You do not pierce this posterior rectus sheath. You just remain on that and deposit local anesthetic under the rectus abdominis muscle and over the posterior rectus sheath. So, what blocks do we need for different things? We're going to now discuss briefly because this is important. Like I said, it's important to know the surgical anatomy. Now, this is the incision which you normally actually see in open cholecystectomy. It may not be such a big incision for some experienced surgeons, but this is the cocker sensation, and obviously, if you actually are actually looking at that, then you give rectus sheath blocks on both sides because the incision can not only extend to the other side. One second thing is that there is crossover of the nerves segments can always occur. So on the top, give the rectus sheath block on both sides, and tap block just under the costal margin. Okay, can be used. You can also use paravertebral blocks. Okay, you can use erector block as well if you actually are comfortable with them. This is a midline laparotomy, and in this case, you would actually need to actually give four quadrant rectus sheath block, so that will cover the top part, the bottom part of the rectus muscle, and then you can actually use classical tap blocks on both sides to cover the midline. You would need large volume, so in this case, you need to be careful with the local anesthetic. A lot of times, 0.25% chirurgine is or levobupivacaine is good enough, but sometimes you might have to further dilute it. So the volume is important. Do not exceed 2 milligram per kg of levobupivacaine or bupivacaine. Just dilute it to that volume using saline or distilled water. That's fine. Okay. So for incision below the umbilicus, okay, lower abdominal laparotomy is sometimes done, not very common. In that case, you can actually do a rectus sheath block. This is like your paraumbilical block. So you will actually deposit local anesthetic just above the umbilicus on the either side. You just go around 4 centimeters or so from the center and deposit local anesthetic like a rectus sheath block. So go through the anti-rectus sheath, feel for the bounce or the posterior rectus sheath and deposit local anesthetic, and also do the classical tap blocks. Okay. For a phalansteal incision following the cesarean section, you can use iliogonal ilioepigastric block or classical tap block in the top. Okay, yeah, the triangle of Petit block. So that is also very good. So it's like a posterior tab block, classical tab block in the triangle of Petit. For this kind of incision, this is a paramedian incision, vertical paramedian incision, because it's one side, then all you need to do is actually do the rectus sheath block and tab block on just one side. So that's the greatest advantage of the vertical paramedian incision. You don't actually have to do the bilateral blocks. Now, incision for classical incision for appendix surgery. So it could be McBurney classical and modified incision for appendectomy. In this case, either you can use a tab block, posterior tab block, or the quadratus lumbar block, where you actually pierce the your transverse abdominis aponeurosis and deposit local anesthetic posteriorly, gives a wider incision, okay, spread of local anesthetic. This is hernia surgery. We have already actually discussed that. You actually can see the spermatic cord here. There. So iliogonal block and tap plane is the preferred that. Tap block on its own has got higher failures. This is a paraumbilical surgery, and like I said, all you need to do is a paraumbilical rectus sheath blocks to go around 3 to 4 centimeters medial, just above the umbilicus on the lateral side, and feel for the pop through the anterectus sheath. Move a little bit in until you feel the bounce over the posterior rectus sheath and deposit local anesthetic on either side. Works very well for the paraumbilical hernias. This is a very extensive incision, also known as the Mercedes-Benz incision, or rooftop incision, or bilateral Cocker's incision. If you're actually doing anesthesia for this kind of surgery, you need to do a rectus sheath block bilaterally and tap block below the costal margin. Okay, combination of this rectus sheath block and subcostal tap block is also described as subcostal tap. Okay, by Peter Hebert, but that is an ultrasound guided technique where long needle is used, and you go from the xiphoid just follow the subcostal margin and keep injecting local anesthetic. So you move from doing a rectus sheath block to a tap block from one point to the other. So that is the subcostal tap. But here you combine just the rectus sheath block, loss of resistance block you give on the top, the first two quadrants, top quadrants, and the tap block just below the costal margin. This is a abdominal paramedian incision, sometimes used for like dew perf. In this case, again, you can actually do a rectus sheath block on one side because it's paramedian, so just doing 2-point rectus sheath block on the side of incision. It is usually left-sided incision, so left-sided rectus sheath block is done. Now, laparoscopic surgeries, some people believe that local infiltration is more than enough, but if you're doing local infiltration, ask your surgeons to do the local infiltration before the surgery. So, if you are doing a standard laparoscopic, you want to do the blocks, you need to do the rectus sheath block. So, you do rectus sheath block on the top, that is at the just below the xiphisternum, and you do a paraumbilical block for the port, which is going to go in umbilical. And you normally see that there are two ports on the right sides, and that can be covered by the right-sided tap block. You again need to discuss with the surgeons. If your patient is obese, they might actually do, a port on the right, on the left side as well. In that case, doing a 4-segment or 4-quadrant tap blocks also work pretty well for these cases. So this is, I think, looks like a surgery for abdominal hysterectomy. So there's multiple ports. They go above. So unlike in the your laparoscopic cholecystectomy, the port is coming above from the above. Okay. So you need to do a paraumbilical rectus sheath block because this is the port is coming from above, and you can do bilateral tap blocks. So these are for laparoscopic hernia surgery, total laparoscopic hysterectomy, or lap-assisted vaginal hysterectomy. You need to discuss and find out where the incision and ports are going to be. And accordingly, if you know the surgical anatomy, you can actually do the block. Okay, okay, yeah. Okay, so this is a classical tap block we are actually showing here. So this is using a needle through needle technique. I take a big needle, pierce the skin, and through that I'm going to introduce a long block needle. Now these block needles we use for nerve stimulator techniques or for ultrasound. These are short beveled, and so you can actually see the bounce. You can actually see, so you need to actually feel for a bounce and then feel for a click as you go through the first there. Okay, yeah. Okay, so first the external oblique. It's also important that if you are not actually feeling the clicks properly, you angle your needle. Okay, you angle it caudally or cranially, because sometimes the fibers actually tend to split rather than you actually feeling the pop. You just actually see it. The fascias may not be as strong, especially in the elderly patients. And once you have got it, you don't actually need to hold it. The tissues will hold the needle. This is a let go technique. You always aspirate after every 5 ml of the local anesthetic injection, and once you've injected. So in this case, I actually also did an ultrasound to just show how the local anesthetic actually has spread. And if you actually observe that closely, you will actually see that on the screen. You can actually see the external oblique, internal oblique, and you can actually see transverse abdominis, which is actually pushed down, and that is called the lens effect. And that so this yeah, okay, yeah, okay, okay. So this is the showing the landmarks. So on the right side of the cranial end, so you can actually see a V shape, that's a xiphoid, and we have marked the 4 points where we are going to give the rectus sheath. So you can actually see that as a paraumbilical because this is a patient who was going to actually have laparoscopic cholecystectomy. So 2 marks below the xiphisternum and 2 just above the umbilicus. So on the top is the head end where you can see the inverted V. And we also going to actually do a subcostal block just below subcostal tap below your costal margin in the mid-axillary line. So these are the things. So we tend to mark. So this was actually in a workshop. So it's nicely shown. So we have actually gone along the costal margin. Keep following it till you reach the anterior axillary lines and go slightly below the anterior axillary line. So sort of midway between the anterior and posterior. So mid axillary line, I would say that. Okay. So those are the important landmarks for the yeah. Okay. So here this is a block we're going to show. This is one of the techniques. So in all patients, you can actually hold the skin, pinch the skin, and this is important in patients who have are obese or patients who have very lax skin. You can use that technique. Pinch it, go through the skin and the subcutaneous tissue, and then you start actually feeling for the bounce. Okay, so it's always bounce and pop, bounce and pop. So keep bouncing it. Your fascia are tough. You feel okay. So uh, you tend to actually feel two bounces. Okay, so bounce on the external oblique, then bounce on the internal oblique at two. So once you felt the pop through the internal oblique, then you will actually deposit the local anesthetic for the tap block. So this is the subcostal tap or tap block below the costal margin. Next, we will actually see the rectus sheath blocks. And okay, so this is the first approach. You can actually see that this has been done just above the umbilicus. So this is the para-umbilical rectus sheath block. And once you actually feel for the bounce over the posterior rectus sheath, you are actually going to deposit the local anesthetic over the posterior rectus sheath. You do not actually pierce the posterior rectus sheath. And like I said, the tougher one is the anterior rectus sheath, and the posterior rectus sheath is actually much thinner, so it's easy to pierce it. So avoid piercing the posterior rectus sheath. So even if it pierces, you're not going to actually do any harm. Okay, okay. Now, this is the technique we actually use. So here, a blunt needle is used, and we can actually feel the bounce on the posterior rectus sheath. It looks like the video of that stopped. Okay, you can. So here you're actually seeing the bounce on the posterior rectus sheath, and you inject the local anesthetic, and you will actually see something beautiful here. And this is very important to understand with the loss of resistance blocks, landmark loss of resistance blocks. So we injecting 0.25% levobupivacaine at each point. So here we would have used 40 mLs to 60 mLs. Okay, you actually can see that the local anesthetic. So this only happens if you're in the right plane. If you're in the muscles, so if you're injecting local anesthetic, you're in the muscles, you're not in the right plane, the local anesthetic will get actually seep into the muscle fibers, and you will never see this return back. You don't see this return back as well all the time in the thinner needles or in needles which have got external tubing. But with hypodermic needle, you always actually see this very well. Okay. So coming to this end of this lecture, so we're going to just summarize the whole thing. So as a part of the general anesthesia, we need to go through the pre-op checklist. We have the IV access and monitoring, and once we have that, then we do the induction of anesthesia. And all you need is propofol. You don't need anything, no opioids. If you give the right dose of propofol, you can actually insert the supraglottic devices very easily. Once the patient is breathing spontaneously, so before I give the block, actually I keep them on oxygen, nitrous oxide, and sevoflurane. It does two things. One thing, nitrous oxide actually provides analgesia for the block. Second thing, I'm building up by the second gas effect, building up the concentration for sevoflurane much more quickly. And once this is happening, now I also give IV dexamethasone and IV diclofenac. You don't want to give these two drugs in patients who are awake because dexamethasone is painful and it also can cause perianal itching. IV diclofenac need to be diluted in minimum of 20 mLs and if possible 100 mLs of saline and give it as an infusion. So once this is done, then the regional anesthesia technique is done, whether you do rectus sheath block, tap block, depends on the surgery, type of surgery. So knowing the surgical anatomy, discuss with your surgeon always. Where is going to cut, where the ports are going to be, what technique are they going to use? Are they going to use mesh? Are they going to use tacks? Okay, you need to actually know that. That's why it's very, very important to have good communication with the surgeons. Intraoperatively, tend to give IV magnesium sulfate. Okay, and if I'm not able to actually give block for whatever reason, then I can actually use lignocaine and be mindful that the surgeon may also be using local infiltration. So you need to be actually very clear in how much amount of local anesthetic the surgeons can use for local infiltration if you're not used block techniques. Then, before the operation ends, 20 minutes before, I give the IV paracetamol. But if you have not used block, you can actually use IV paracetamol with small dose of tramadol. You just need 25 for females and 50 milligrams for big built or well-built patients. You can give it at the beginning rather than give it at the end of the surgery. And then at the end, you reverse everything and you take the patient to the recovery. And don't forget to prescribe analgesia, regular analgesia, and antiemetics. Okay, the analgesia to be, if possible, given by mouth and by the clock. Remember, by mouth, by clock. Okay, and for at least 36 to 48 hours minimum. Okay, and after that, they can always go on as and when required. So if you look at abdominal thoracic surgery, there are somatic component and visceral components. For somatic component, you can use regional anesthesia technique, whether you use abdominal block, you use parotid block, erectospinal block, spinal opiates or epidural, do use it as part of your technique. For visceral pain, you can use multimodal analgesia, which all patients can get dexamethasone without any doubt, diclofenac, even if they have magnesium sulfate. Using other agents like lignocaine, if you're not going to use regional anesthesia technique. Using clonidine infusion, dexmedetomidine infusion along with or without ketamine. Paracetamol with or without tramadol will depend on whether you have used regional anesthesia technique to your advantage or not. So guys, multimodal analgesia is part of every technique, whether you're using regional anesthesia alone as these technique, always give them at least 2 or 3 components of the multimodal analgesia. Everybody should actually get dexamethasone, right? They should get non-steroidal if they have no contraindication to it. And you can use magnesium sulfate without any problem if you use as an infusion. Okay. Paracetamol is a very safe drug to use. It can be given orally. You can even start your multimodal analgesia in the preoperative period. You can prescribe oral paracetamol, ibuprofen with or without PPIs. Okay, and oral diclofenac, you can get coated tablets, slow release tablets as well now. And then you can use fixed dose combinations like paracetamol with tramadol for post-op analgesia, especially in patients who have low pain threshold or patients who actually have history of painful surgeries in the past or bad experience in the past. Thank you everyone for listening to this lecture, and we can have some question answer sessions.